So I have done my graduate level neurology video project on Parkinson's disease and the impact on the Substantia nigra. So Parkinson's disease, which I may refer to throughout the PowerPoint as PD, is of personal interest to me because during my fall internship, one of my favorite patients in inpatient rehab was diagnosed with Parkinson's disease. So we saw him as SLPs for voice. He had come into rehab with something else, but then while he was there, his wife asked him to be seen by the SLP because of his voicing. She said that she had a hard time understanding him, that everything was mumbled and kind of ran together. And so as we completed an evaluation and got to know him, we found out he had previously received intensive voice therapy at a different institution, and that he was having frustration because he felt like he was shouting at people when people complained that they could not hear him or understand him. When I originally met him, he was kind of intimidating, but as I got to know him and really started to think about what I knew about Parkinson's disease and tying in what I've learned through this video project, is he had kind of the typical symptoms of Parkinson's. So he had the masked facies, where he just had a very limited range of facial movement. So he looked like he was stern, just had a very blank resting face. He had tremors. He had a deep brain stimulator, which I won't go into detail in this project, but it was interesting to learn more about that through the research. But yeah, because I really enjoyed this patient, I wanted to know more and kind of connect what I knew about him with what was happening in his brain and seeing how I can apply that in future patients. So a little background on Parkinson's is it is a degenerative disease that impacts the substantia nigra. And I'll go into more detail in a few slides, but basically what this causes are tremors, even at rest, bradykinesia, and overall rigidity. So for us as SLPs, we're going to see kind of slowed movement of the face, especially the lips, maybe some problems with articulation, hypernasality. There's a slew of things we might see, as well as dysphagia that can impact all four stages of the swallow. But because I don't want to go into the treatment or kind of get off track with that, I'm going to talk about the three areas that related to our class that I found in my research. So we're going to talk about the substantia nigra, calcium and potassium channels, and firing rates of neurons. So to begin, like I said, Parkinson's evolves from degeneration of neurons in the substantia nigra. So this structure, which we talked about in lectures or heard from lectures, is a structure within the midbrain. But it's composed of two very important parts, which are the pars compacta and the pars reticulata. If you read research or dive into the literature about Parkinson's, these two just flood the pages, and it took me a while to really wrap my brain around exactly what they are. But for the pars compacta, this is where you're going to see that neuron loss of dopamine. So dopamine, which I will discuss in the next slide, is the neurotransmitter that is degenerated, which is going to cause the motor problems, the impact on voluntary movement, and so forth. So that's the pars compacta, and then there's the pars reticulata. From what I read in the research is that this part of the Substantia nigra typically stays intact, but there is an important protein, which is a calcium binding protein called PV, that causes changes in the brain. I'll discuss it further once I talk about calcium channels, but that's important to know that protein resides in the reticulata, but you're going to see the neuron loss in the compacta. While there's neuron loss in the compacta, there's other things happening in the reticulata that are going to present as Parkinson's disease. So overall, this is all a part of the basal ganglia network. So it's going to cause the movement disorders you see with Parkinson's. It's going to affect posture, automatic movement. And what I gathered from the research is that there are so many different parts of the brain, kind of these smaller structures, that come into play when you're talking about Parkinson's. So because there's so many connections and fibers that link all of these sections together, it's not a clear picture, at least to me, of one structure solely being impacted. There's a lot being impacted that causes the symptoms you see for Parkinson's disease. Like for instance, the striatum, which includes the putamen and caudate nucleus, is impacted. So once you see that degeneration in the compacta, that impacts how information is processed in the striatum, which is going to cause an imbalance in the thalamus, the globus pallidus, and the cerebral cortex. So the calcium channels, we've talked about these in this class because they're important for this information being processed throughout the bodies. So for Parkinson's, it appears that both calcium and potassium channels are impacted. So the typical electrical potential you would see with a typical neuron is changed. There's actually hyperpolarization of these dopamine neurons, that's the DA. And so this hyperpolarization causes a degeneration. And these dopamine neurons, these transmitters, which we've talked about in our class, from the axons to the dendrites, these are what carry that information to and from. So these are extremely susceptible to degeneration. The research wasn't clear on why, but it could be more current research is coming out about it now, but from what I found, it wasn't clear. But what happens is this degeneration, this lack of dopamine, is going to throw off the calcium homeostasis. And so that's going to send these channels, they're going to be impacted by a change in the metabolic stress. So if these channels are blocked or start to degenerate, the neurons are at risk for stress or degeneration, which is going to cause Parkinson's disease. And then firing rate of neurons, we've talked about this mostly with the myelin sheath and how they jump between the nodes, but we know that it's extremely important for these neurons to fire efficiently and effectively so that you can receive communication throughout your body. So I talked about that calcium binding protein earlier, PV. So this protein is found in neurons with rapid firing rates. And so if there is an increase in firing rates for these neurons, it's going to change the electrical activity. It's, from what I saw, is that in the compacta, pars compacta, it starts to become really spontaneous. So the firing is irregular, and as they classified it in the literature, bursty. So even if you have different lesions in this area, so you can have a lesion in the pars compacta or in the medial forebrain bundle, that firing rate is going to be impacted in some way, whether it's increased or decreased, but that's going to change how the neurons fire. And so that's going to equate to how information is processed. That's going to contribute to this slower movement, that the lack of control with the tremors, and it's really just going to present itself in how you're seeing the symptoms of Parkinson's in your patient. But that's just a really quick overview. I found the literature to be hard to decipher. It really talks about a lot of different structures in the brain. It's hard to boil it down to a 10-minute presentation, but there's a lot going on with Parkinson's, and I think the research upcoming is going to be interesting to stay on top of. So yeah, thank you.